for giving this opportunity. I'm Dr. Santosh from Assistant Professor from Government Medical College, Nizamabad. Today, just I'm presenting one interesting case, or usually it's we don't do regularly. Okay. So this is about a 29 years old male. Came with a road traffic accident. He had a laceration over the volar aspect of the right side of the wrist, and also he had swelling of the wrist. He was suture was wound was sutured in the emergency and later referred for radiological evaluation. So today, here we have the regular X-rays which we take for wrist joint. That is the same PA view, oblique and true lateral views. As the staff was discussed, I need to mention about nothing much more about this. Here it's purely an ligamentous injury, that is lesser arc injury. And also there is a scapular dissociation with complete volar dislocation of the lunate. Okay, and there's a lateral view with a spill cup sign. And I need to discuss any other views will be useful in same type of lunate dislocations, or where there is you have doubtful scapular dissociation. It is like stress views, which usually I take after once the swelling subsides, that is after 3 to 4 days, I go for stress view. If only there is the discrepancy in clinical finding and radiological findings. So here I need to mention this staging of lunate dislocation, which is described by Andrews. Here, lunate dislocation is nothing but one stage of perilunate dislocation. Here, as you see, there is perilunate dislocation. That is capitis dorsal to the lunate. This is the first stage of dislocation, and most of the others will view this as lunate dislocation as next stage of perilunate dislocation. Here, once the capitate goes dorsal to the lunate, it comes back rebound. That is rebound phenomena, which displaces the lunate completely towards the volar side. As Mayfield states, he states that complete volar dislocation or volar dislocation of lunate, like complete tear of volar radial lunate and lunotricutal ligaments, that is small and large ligaments of radial lunate. So I need to conclude that this lunate dislocation is nothing but it's an extension of perilunate dislocation. So most of the people will be confused with perilunate lunate dislocations. So this is the thing with lunate dislocation. So in emergency department or here, what should be assessed? In perspective of lunate dislocation, we should evaluate the median nerve symptoms. That is, the patient having any median nerve compression, tingling over the index finger, middle finger. So other than that, in this patient we have missed, as he has laceration over the volar aspect of the wrist, which is just about 1 centimeter. So it was neglected or overlooked in the emergency department, and we did not do any complete evaluation of other neurology. So also in emergency department we have failed with close reduction of lunate. This is because here, as you see, there is complete dislocation of lunate, the volar part, almost in the carpal tunnel. So, as stated, this is stage 2, which I am present the case is a stage 2 of lunate dislocation. So it is difficult to replace the lunate mostly in the stage 2. This is the common reason for failure of reduction in emergency department. So this is the attitude of the hand. Actually, this is not the patient, we have replicated it. This is the attitude of the hand, of the patient's hand. He had a laceration just proximal to the wrist crease. So here the attitude, as you see, there is flexion of DAP, PAP joint of middle finger, and also the index finger. It has the attitude of tenodesis. But when we come to ring finger and little finger, PIP is flexed, but PIP is in extension in less extension when compared to the middle finger. So this attitude of the hand in the emergency department or any with patient having any small laceration or even in 1 centimeter laceration when it's causes like glass cut injuries, then you should have highly suspicious about the tendon injuries and nerve injuries at the level of the wrist. So here I need to discuss the management of this case, whether it's open reduction or closed reduction. As I mentioned, in emergency department we are unable to reduce it, so we went with open reduction. Open reduction, as you see, he had just 1 centimeter of laceration over here. So we have explored from that laceration. So we found that entire ulnar artery, nerve, and FDS of ring and little finger was cut. So this is the reason for attitude of ring and little finger previously. So here we found that this is the extruded lunate opposite in the carpal tunnel. So we went with dorsal approach also, that is dual approach. As you see here, this is a type 2 of tear we found in the scapholunate ligament. That is the radial part. That is part of the scapholunate ligament is preserved with avulsion from the lunate aspect. So what we did was, it's a must that you should be repairing the scapholunate ligament when you have complete tear of dorsal part. So here we did not have the luxury to use the bone anchors, so we went with tunnels in the especially lunate aspect and scaphoid aspect. We repaired it with tunnels and using the 3-0 ethibond. So this is what we did. So these are the post-op X-ray. Coming to reduction.
Thank you, sir. Now we request all the speakers and panelists to come onto the desk for panel discussion. Certificates and honoraries. Dr. Gopinath, sir. Dr. Abhijit, sir. Dr. Sunil, sir. Dr. Neeraj, sir. Dr. Santosh, sir. Persons, Dr. Nagendra Babu, sir. Dr. C. Ramu, sir. Dr. Koneru Rao, sir. On to the
Start the session. Can I call upon Dr. S. Mohanty sir? He will be speaking on primary TKR in periarticular post-trauma osteoarthritis.
Thank you, Chairman, sir. Greetings from the city of Mumbai and from the Department of Orthopedics, KM Hospital, Mumbai. We have the largest orthopedic department in the country. Of course, Madras Medical College also has got 300 beds. So we have 300 beds, 24 postgraduates per year, managed by 6 units. It's always it's an honor and a pleasure to stand here and talk here in the 7th annual conference of Telangana Orthopedic Surgeons Association. And I thank the Honorary President, Honorary Secretary, and the entire executive committee as well as the entire organizing committee, especially Dr. Rakesh, for inviting me here. So friends, total knee arthroplasty for post-traumatic arthritis. Can you please change it? In the patients with post-traumatic arthritis, they are affected by pain and disability. And total knee arthroplasty is probably the most successful salvage procedure in these kind of conditions. It becomes more complicated when it is associated with infection. Next slide, please. So this is a complex problem which involves maybe intra-articular fractures giving rise to arthritis or extra-articular fractures leading to malalignment, again development of arthritis. It may be soft tissue injuries or meniscus, cartilage, ligament, any injury can lead to arthritis as well. And the prevalence which has been described in the literature is that following a periarticular fractures, the periarticular soft tissue injuries, the prevalence is to the tune of 10 to 44%. And radiographic signs usually takes about 2 years to somewhere 11 years to appear for this arthritis, the cartilage to go away and arthritis to develop. There are a group of challenging procedures because there are scars, multiple scars, contractures associated which needs to be taken care of. There is instability, there is malalignment of the limb, there is malunion in certain parts, there may be bone defects, certain parts need to be built up. There are certain retained internal fixation, either a nail, plate, whatever screws that needs to be taken out. There is always a possibility of latent or low-grade infection. One needs to rule it out by doing a pre-operative ESR, CRP or a aspiration. And there is a high rate of complication to the tune of 36 to 63%. So one has to plan these patients well, have a pre-operative planning. In addition to the routine epilateral and skyline views, one should have a full-length hip, knee and ankle view X-ray, as you can see here, to look for the alignment, to look for the obstructed canal, to look for the implants which are there. If there are multiple scars, next. So one has to plan the incision well. So if, as you can there, multiple scars. So if you can pinch the skin with your hand, then probably that scar is a matured scar and that will not give rise to post-operative problems. But if you cannot pinch the skin, then you have to be very careful and you have to take always the most lateral incision because the blood supply to anterior part of the skin comes from the medial side. Then you can go for a medial parapatellar approach. You have to keep constrained implant standby. Next slide, please. And you need to keep a hollow mill always. Sometimes the screws, there may be broken screws which will be difficult to take out. And of course the infection workup is important, or else intraoperatively if you find any granulation tissue, send it for frozen section in order to rule out infection. Next slide, please. So in our series, from within these 9 years, there are 148 cases out of this nearly 5,000 cases. The incidence is about 3%. And these are younger age group of patients. Average age is 40 to 50 years, and the average time since injury was around 5 years. There are 4 groups of patients: extra-articular fractures giving rise to arthritis, intra-articular fractures giving rise to arthritis, soft tissue injuries giving rise to arthritis, and finally infected joints. And the average preoperative range movement are much less compared to osteoarthritic knees. So the first group, extra-articular fractures. For example, the 72 years old female history of trauma 12 years back. There are only 8 degrees of angulation in the tibia, but that led to the development of arthritis. So here, because of less of malalignment, you can take the cuts, compensatory cuts, little valgus cut on the tibial side in order to restore the mechanical alignment there, and that is the lateral view. Next, the follow-up shows it's almost 8 years follow-up that limb alignment is maintained. Next, and if you draw the hip, knee, ankle axis, there is the mechanical axis is neutral and the restoration of the function for the patient. Next slide. On the other hand, this kind of patient, when there is a severe malunion because of treated conservatively 65 years old male with a fractured tibia. Next slide. You have to plan this X-rays well. So draw the line. Next. This is the axis of the tibia. Next. So draw a line which is perpendicular to the axis of the tibia, as you can see here. Next. So there is a lateral collateral ligament which is lax. Next. So if you are taking so much of cut, there are chances of medial collateral ligament may get injured, and there will be gross instability in the knee. So in these kind of cases, it requires extra-articular correction. Next. So almost 34 degrees of angulation. So do a osteotomy extra-articularly. Previous slide please. Previous slide please. Previous slide please. Okay, so do a extra-articular correction. Put a tibial stem extender so that it acts like an intramedullary implant, and then restore the mechanical axis of the lower limb. Next slide. So second group is intra-articular fractures like this, which is malunited. So there are implants inside. You take out the implants, but if you are able to take out all the screws, then you need to put a stem extender in order to bypass the screw holes so that there is no stress rises. Intraoperatively, you need to check the stability. In this particular case, there was patella baha pre-operatively, though post-operatively patella baha is there, but it's a useful thing that the patient may not get, any disability except there is some restriction of the movement. Next slide, please. But in this kind of patient, which is 9 years old injury in a 52 years old male, you couldn't take out the all the screws. So in this particular case, next. So we just take out the plate and take out the distal screws, and you can leave these screws intact there. Next. And so put a primary joint in. Next. So that is the pre-operative exercise, that is the post-operative exercise. Since you have left the screws in here, that you can put a primary component there. But remember, the placement of the femoral component is slightly lateralized, and because of the procurvatum deformity on the femoral side, you have slightly placed the femoral component. So even if without navigation, if you have planned your surgery well, you can have a good post-operative exercise like this. Next. And have a function like this. Next. So that is the gait of the patient. That is the function that pre-operatively he had around 90 degree of movement. So here post-operatively also almost 4 years follow-up shows that it is a 90 degree movement. Next slide please. Now this is a neglected Hoffa fracture, which was operated, lateral Hoffa fracture, which was operated, screws were removed. There is a gross valgus instability. Next. The patient is previous slide please. Yeah, next. Okay. The patient was walking with a hyperextension and valgus gait, and here the Hoffa fracture was fixed with the screws, and then the cuts were taken perpendicular to the tibial cut. So that is the Hoffa fracture. It fixed with screws, the Harvard screws. Next, since the epicondyle is affected, so here we have taken a cut perpendicular to the tibial cut, and here a primary prosthesis has been put. And that is the style and view. Next slide, please. Next. So that is the function in 5.5 years follow-up. A Hoffa fracture which has been fixed and reconstructed during a total knee replacement surgery, full restoration of the function, and there is no pain. Next. So this is group 3, soft tissue injury. Where there is meniscus injury or ligament injury, that will give rise to arthritis, and these kind of cases you just do a primary total knee replacement and look that your instability is corrected and you have done a good ligament balancing. Next. The fourth group is an infection group. Here is a patient 54 years, 2.5 years old trauma, hemarthrosis, aspiration has been done, got infected. Next. These kind of patients require two-stage reconstruction. So this is the articular cartilage entirely gone. Next. In the first stage, you take the cuts like a TKR, but do not prepare the tibia and do not take intercondylar bone cut on the femoral side. Next. Put the cement spacers there. Next. That is the X-ray with the cement spacer and calcium sulfate pellets along with antibiotics there all around the joint. Next. And second stage reconstruction with a primary total knee replacement. Next. So outcome, the average operating time is more, almost 1.5 to 2 hours in this kind of patients. You get an average fairly good range of movements until about 90 degree or a little less maybe that. And though the knee society and the function scores, they improve to a greater extent, but there is a high complication rate to the tune of 30 to 40%. Wound problems is the usual complications. There are some patients who did a manipulation or anesthesia, and 3 patients had a paresthesia also. Next. So what the literature says, 2016 paper on 170 patients, 83 soft tissue injuries, 87 fractures. Average operating time is again almost 2 hours, 1.5 to 2 hours. Length of hospital stay is slightly higher compared to primary osteoarthritis group and 10.6% complications. Again, Journal of Arthroplasty paper, there is higher superficial surgical site infection, prolonged operating time, increased length of hospital stay and 30-day hospital readmission. Again, Journal of Arthroplasty paper shows post-traumatic TK continues to have worst outcome than osteoarthritis. Next. So to conclude, dear friends, total knee arthroplasty for post-traumatic arthritis is more complex and demanding, younger age group of patients, and there is a higher operating time. Implant removal sets has to be kept ready and always have the broken screw removal set. You have to keep the constant implant standby, more associated complications, and outcome is poor compared to the primary osteoarthritis group. Next, and thank you for your patience. My candidature for the Vice President of Indian Orthopedic Association this year elections, many of the Telangana Orthopedic Association mobile number has not been updated. Kindly go through this website ioindia.org and update your mobile number so that you can give an online vote when the voting process starts. Next, I thank you for a patient hearing and again thank for inviting me here. Thank you.
Thank you, Dr. Mohan. Any questions from all? For almost every conference, he will be presenting some papers. Thank you. Go ahead, Dr. Mohan.
Orthopedic surgeons, the usual problem is there is a love-hate relationship between PRP and orthopedic surgeons. There are people who swear by it and some people who say it's a bogus thing. So the disclaimer here is what we are going to present today is part of the reason for failure of PRP methodology is that you don't get proper counts and all. So this kit will give you good counts, and if you still find PRP useless with using this kit well, you are correct. And for those who like it, this kit is going to be a definite help. So the reason why platelets are in the spotlight nowadays is because they have been found to be a safe, non-surgical method and a biological method for musculoskeletal injuries as well as osteoarthritis. So they've been called these originated from US and it has been described as the magic bullet. And this was because star athletes in that time, they used platelet-rich plasma and claimed that it gave them very good results. So that's how the whole buzz about the platelet PRP started. And when we got interested in it, then we looked into the market because we wanted to have a kit which gives us good platelet counts. And then we found on one side, we have the cheaper kits which are quite affordable at 600 to 800 rupees, but the platelet counts they give or concentration they give is pretty low. And on the other end, you have the high-end kits which are very expensive, and like I said, when you have a questionable or doubtful method of treatment, you always want a good result. So with that in mind, we started to design a PRP kit which would approximately be as expensive as an injection of hyaluronic acid. So what happens is, when you have newer technologies, you always find that the price of the treatment or the procedure goes up. And that is where this concept of disruptive innovation comes in, because in developing countries or in cost-sensitive markets, people want to come out with cheaper alternatives to these expensive patented instrumentation or kits. So this is what we started doing. So this is actually a name has been coined for that. It has been called Jugaad, or the Indian way philosophy of improvising and innovating. So the goal here is to design a PRP kit to get a platelet concentration of above 10 lakhs or 1 million of platelets per microliter. It should be a point of care procedure because the surgeon has to do it without involving third parties. Then you have to assure sterility, and above all it should be low cost. So the thing is, the key here is to achieve a platelet concentration above 1 million, because that figure has been found to increase the repetitive capacity of the tissue healing property. So first what we did is we analyzed the cellular components, because the method of centrifugation is nothing but a physical process. The platelets, as you know, are the smallest blood components, about 2 microns in size. And the physics behind platelet extraction is you first do a soft spin, and that will make the larger cells, that is the RBC and WBC sediment. And at higher speeds, the platelets will sediment, and finally from a platelet count of 2 to 4 lakhs, you will increase it to about 10 lakhs. So in a nutshell, what we use is a 2-spin technique. In the first spin, what happens is you do a 1500 RPM into 15 minutes. The serum along with the platelets is left on top, while that serum is aspirated and subject to a hard spin, which of 3500 RPM for 7 minutes. That will produce a platelet pellet at the bottom. That is what? That pellet is reconstructed and used for your clinical procedure. So the first thing that comes to mind is the anticoagulants. After discussing with a lot of people, the ideal anticoagulant which is approved by US FDA is ACDA. The heparin and sodium citrate do not give you adequate counts, and the EDTA which comes in vaticanus is an absolute contraindication. So in the developing the prototype, this is what we did. We first tried to establish our proof of concept. Then it is not for a clinical application. Initially, we used to take informed consent and take draw blood from the post-operative, patients in the OR and do it. And we evaluated mainly the platelet counts and found out whether it is an aseptic technique. And for ACDA, what we did was initially we drew blood from a 500 ml bag used in the blood banks. Because ACDA vials are not available in smaller volumes. So the important step in maximizing the platelet yield is we need to use a scalp insert, because the movement of the needle inside from a hypodermic syringe in the vein itself can start activating the platelets. So the syringe, what we did was initially we covered the syringe, the nozzle of the syringe with a cap from an insulin syringe, and as you know, a full syringe will not fit into a centrifuge. That's why we slipped the piston, and the flanges also were cut so that it will go into the bucket of the centrifuge. And then to transfer the serum for one syringe rather, we used a 3-way cannula. And because if you use a needle to draw the serum, there is always a chance of contamination and platelet activation. So these are the various steps, but that was a very crude method because that was only the prototype. So from this what we got was, we did about 144 samples. Of those 12 lakhs and above, 15 lakhs and above, we got in 80% of the patient, and more than 10 lakhs we got in, 81.9%. So that kind of validated the methodology. And if you see every draw we do, we will study the platelet counts. If you see the first one, that's the pre-op count, we found that the platelets are 3 lakhs here, and the WBC count is 13,000. And if you see the second, after the extraction, the platelet count is increased to 21 lakhs or 2.1 million, and the W count, PC count is reduced to a mere 1600. So you are getting a leukocyte poor PRP here. And all first 50 samples were cultured, and none of them grew any, bacteria. So it was deemed to be a aseptic technique. So the design cycle, what happens is the proof of concept and prototyping was established. Then what we have to decide is when we are doing a kit, we have to do what is called a minimum volume product. So that means what is a or minimum viable to make it cost effective. So these are the various things we use, and the most difficult part we found was the HDA vials, which had to be custom manufactured for use here. So the thing is, question, would you like to draw multiple samples from a bag when you're using a patient? So that was the first problem that we addressed, and we had a pharma company to make a HDA vial which just had enough anticoagulant to use for individual patients. So this one was the first difficult part in our design. And the syringe caps, what we did was we made a custom designed cap that will fit on the tip of the syringe, and that's how the syringe nozzle can be capped. And if you see, a full 20 cc syringe will not fit into a centrifuge. Hence, the syringes were manufactured with the side flanges removed. And the important part is the piston unscrews from the syringe. There is a spacer here, and the piston has threads. So the piston will unscrew, and then it can go into the centrifuge. So that is the spacer that is in the syringe. And instead of using a three-way cannula, which is a waste of resources, we again designed a syringe-to-syringe connector which can draw the serum, so that the whole process will become a closed procedure. So that is the lever connector, so that it helps the transfer of serum from one syringe to the other. And then even if you have a good product, as long as it is packed like a bag of groceries, you are not going to like it. So the important part is packaging, for one, to protect the contents and give information about the procedure and have a visual appeal as well. And so we then went to design a packaging for that. The kit comes with an external jacket to protect the content, and the kit is inside. So the procedure is written on the back of the jacket here, and that is the kit which is made in a bubble wrap. And once you open the kit, everything required for doing the PRP is available in this kit. So these are the details about the spin, the first spin and the second spin which we use. And the only extra requirement is a centrifuge which has a 50 ml bucket, that is 4 into 50 ml bucket, which can take the syringes. That's the only modification that is required. And this is the hard spin. And once this is the platelet pellet here, you take out the upper layer of serum, which is the platelet poor plasma, and this is reconstituted for injection. These are the various volumes for the conditions that you use. And the question is, does this kit also work like the other ones? So you have this platelet concentration of 2.21 lakhs, and that has been enhanced to 11 lakhs. And the WBC from 5,800, they have reduced to 400. Just give me a couple of slides. So this is how even the present kit works to what we have shown in the prototyping. And these are the various applications. I will take a cue from this and start innovating, because our career is coming to the sunset years, and I think you are the guys to take over next. Thank you very much.
Thank you very much, Dr. Manna. We congratulate you for this. We thank also because of this innovation. I request all the audience to give a big hand. You see, this is the Make in India, what our government needs, what our public needs. You see. Thank you, Manna.
It's a great privilege and honor to stand before here in Telangana, and I'm really thankful to the organizer, President and Secretary of Telangana Orthopedic Surgeons Association for giving me this opportunity. Congratulations, Dr. Amarnath, for really a wonderful indigenous kit, and we need to have a people like you who can do our own things and really replace those 12,000 and 15,000 kit to a mere of 2,000 something. So that was a wonderful thing. Thank you. So, what is Bofas fracture? It's an intra-articular coronal fracture of the distal femur, and it is from the articular surface to the 5 centimeter above the metaphyseal flare. Usually isolated, but it can be associated with other distal femur fractures also. And the only attachment usually is the posterior capsule, so they are very susceptible to displacement on axial loading and knee flexion, and that's why they are very important. Instability of fragment can really lead to a higher likelihood of non-union, pain and disability. Therefore, they should never ever be treated non-operatively. They should always be treated by operative measurements. This is a commonest classification which we all use, where type 1 is a fracture line parallel to posterior femoral cortex involving the whole of the femoral condyle, and type 2 is where fracture is behind to the parallel line, and this is crucial because they are the one which most of them goes into non-union and avascular necrosis. Type 3 is oblique fracture of the posterior condyle. If you look at the AO classification, this is the 33B3, which comes into Bofas fracture. And if you look at 33B3, 3.1 is an anterior and lateral plate fractures, while 3.2 is a unicondylar posterior Bofas fracture, and 3.3 is a bicondylar posterior Bofas fracture. So we are mainly concerned with 3.2 and 3.3 here. Radiology, as we had been in hand section, so for orthopedic radiology is the most important thing, how to diagnose the early fractures. Always we take an AP view. Usually there is a shortened fracture condyle which may give an appearance of varus or malgus malalignment. Many a times you may miss this fracture in an AP view. So you need to really have both AP and oblique view, lateral and oblique view also. And why oblique? Because in lateral view you have the superimposition of image of both the condyles, so undisplaced fracture may be missed, and that's why oblique view is important. Even after having all these three views, in an undisplaced fracture you may really miss the Bofas fracture, and that's the importance that you should get a CT done. So this is one example of plain X-ray. As I said, lateral view, probably you will not be able to make the fracture line here. So you get a CT done and you find a fracture like this. So always have a strong suspicion of an Bofas fracture, and whenever you have a suspicion, get a CT done. So once you have diagnosed, planning is the key to success. The time which a surgeon devotes to a careful preoperative plan often determines the success or failure of the procedure. So planning is the key. What we do, we need to plan which approach we are going to do, how and what are the reduction tools which we require, and how fixation has to be done, the various types of implants which you should have inside the OT once you are planning for an Bofas fracture. So approach depends upon configuration, amount of combination and associated fractures. So you may have a different approach, lateral parapatellar. So why this is not moving? So you may have a lateral parapatellar, medial approach, TTO, posterior approach depending upon these. This is a wonderful publication where they talk about what are the things that determines the approach. So this is one is fracture characteristic, the size, the combination, fracture plane, and then the surgical approach depending upon that, and a type of fixation you are going to do that, and very important, the biology of that fragment, the soft tissue and hard tissue are going to decide your approach. And that also this talks about the fracture characteristic, that how you define which one is a large fragment, which one is a short fragment or a small fragment. For lateral condyle, more than 20% of the fragment is a large, less than 20% is small. For medial condyle, it is the 30%. So how to define large and small? It's different in medial and lateral condyle, and the approach should depend upon large fragment size or a small fragment size. So, for the large fragment, which is an isolated fracture, you may have a direct lateral or medial approach. You may require to buttress depending upon which side the fracture is. For a large fragment associated with other fractures, you will require a parapatellar approach, anterior to posterior screw. Once you have done, then you can do a microplating to combine it with the diaphysis. For a small fragment, which is an isolated fracture, usually a posterolateral or a direct medial approach is required, and you can see then candidate for the IOA this year. And since I am the chairman to CSRC also, I will speak a word about the bone and joint. So can you play the second PowerPoint also? So every year IOA celebrates the Bone and Joint Day on 4th of the August, and this year again we are celebrating. Your state president and secretary is going to give you the whole idea about this. I'll just go through a brief about this. This year it is going to be 1st to 7th August, and this is Monday to Sunday. I'll just speak about the SOP. So we all know the president theme is success with surgical and soft skill, and this year theme is based on the soft skill, and the theme is each one save one, where we would be giving a physical training to every individual, the first responder. Who are those first responders? These first responders are drivers, taxi drivers, traffic police, paramedical, general public, student from college, university and professional college. This is not going to be this time online training. We need to train them physically. Why? Because they are the one who during the trauma on a road traffic accident can really help to save the lives. So that is the purpose to celebrate. So I invite you all to please participate in large number. Everyone try to have one training session in your hospital, in your own college, in nearby college, in nearby society, NGO, with your drivers association, with nearby Thana. And the target is to train more than 1.4 lakh. Since we have 14,000 members, if every member train 10%, we'll be able to achieve this. So this is what I need to tell you about the Bone and Joint Week. Please participate everyone into this. Thank you.
Thank you, Agarwal sir. Respected Chair, my dear friends, senior faculty, there is a very common problem, long COVID. We have been through a bad phase of acute COVID. Now we are into this phase where we are seeing many cases of avascular necrosis of femoral head, also known as osteonecrosis of femoral head. It's a very common problem. Unfortunately, most of the doctors, they themselves are not able to diagnose it early, and they are suffering. We are all seeing day in and day out. And this problem is because we are dealing with end arteries. Just like arteries, those supply the crucial part of the heart, myocardium, say brain, kidneys. So the arteries which are the end arteries in the femoral head are the real cause, and they are the sufferers because of various reasons that go through in the COVID. So Indian data is not available, unfortunately. On an approximation, we have 20 to 30,000 cases seen every year in US, and 10% of all the joint replacements that have been carried out usually are because of osteonecrosis. And it commonly affects young population. Most unfortunate part of it is the young population who are the sufferers, and 50% of them are bilateral. Most common cause is alcoholism and steroid usage.
They are approximately 80% of them are from this category, and 20% we don't find any reason, hence we name it as idiopathic. But in idiopathic cause also, 70% of them have subtle coagulopathy, which goes undiagnosed most often. And in the post-COVID scenario, as I told you already, we are seeing a lot of cases. Unfortunately, they are not recorded. Regarding etiopathogenesis, we all know it is traumatic and atraumatic causes. And with respect to atraumatic causes, I wish to sum up extraosseous and intraosseous causes. In the extraosseous, you have arterial and venous, and intraosseous, you have intravascular and extravascular. Not going into the details of it because these are most often multifactorial. There are all the causes which all of us know, but thing is, how do we evaluate into the most common causes is what is missing at this point of time, and henceforth we end up in late presentations, obviously ending up in total hip replacements. So the most common presentation which they usually neglect is groin pain. They attribute it to some sort of a catch, which usually most of the doctors what I have seen is like they attribute it to a backache or some sort of a hip pain related to seating posture which they have not adapted properly in their own cars over a period of time, but fail to realize that these are all small, simple symptoms which can end up in a big problem over a period of time. And especially when somebody has Cushingoid features after taking steroids, especially after post-COVID, we never have to neglect those kind of cases, and those cases we have been seeing very often, and they don't go into further evaluation with respect to AVN. So on examination there would be slight difference with respect to the other hits in the initial stages, but they are very crucial. Background history, subtle symptoms and very subtle findings to start with, and ultimately they end up very fast in stage 4 avascular necrosis of the femoral head. With regard to the serology, this is the most important thing which usually we neglect, wherein we need to see with respect to uric acid. Hyperuricemia is one of the most important factors which usually will be missing, and lipid profile abnormalities. Any abnormalities in triglycerides, LDL cholesterol, especially these are the things which end up in lipid emboli with respect to COVID and steroids, and also with respect to the microangiopathy that we see in COVID. So protein C and protein S are some coagulation factors, factor 12 and all those things, and protein S being a cofactor of protein C. They are useful to keep our blood in the liquid phase, not to allow undue coagulation happening. A deficiency of protein C and protein S, which we usually don't test very often, and ultimately if they are found to be deficient in any of these patients, they are more prone to have this, and antithrombin 3 deficiency as well. Lipoprotein A we usually neglect. This is one most important independent risk factor of cardiac death, sudden cardiac death. And the same thing is because of the thrombosis phenomenon, thrombophilia that can happen in these cases as well. Homocysteine as well. Young fellows having homocystinemia, they ultimately end up in thrombotic phenomena, and these end arteries will be the sufferers. And antiphospholipid antibody and lupus anticoagulant, these usually go to rheumatologists, and ultimately if they are found to be having, they will be having many symptoms as well. Radiography, initially X-rays, they don't give you anything. Literally only at stage 2, very rarely, and stage 3, we end up finding some features in radiography. They take 3 to 6 months of time, and ultimately we will be losing the precious time in these patients. At a later stage, ultimately we are left with no other option than joint replacement. Bone scan is a useful investigation of choice, but unfortunately its sensitivity is very less. It extends up to only 70%, and sensitivity as well as specificity also is very less. Henceforth, it can detect that acute episode within 1 week, but unfortunately it can be false positive as well. Henceforth, MRI is the gold standard as of now, which can detect the changes of avascular necrosis as early as 3 weeks. So if somebody is having these features of Cushingoid and hyperuricemic, metabolic syndrome, post-COVID, you can as well go for an MRI within 3 weeks after the first symptom of a hip pain complaint from these patients. So usually when it comes down to orthopedic surgeons, what to see in an MRI is always a big question. The findings in MRI are very clear and succinct in avascular necrosis of femoral head. Usually T1 weighted, T2 weighted and fat suppressed images is what we usually discuss. In all these three sequence of images, you see heterogeneous lesion which is clearly demarcated. A narrow zone of transition is what we need to see. A narrow zone of transition, heterogeneous lesion, narrow zone of transition, heterogeneous lesion, narrow zone. This is T1, this is T2 and this is stir image. So in all these three things, you find a heterogeneous lesion which is having a narrow zone of transition, always go in favor of avascular necrosis. Sometimes we may have a lot of edema in the neck and greater trochanteric region, which usually we see in bone marrow edema syndrome or transient osteoporosis of hip. So that gives you a confusion. But this comes up slowly and insidiously, but transient osteoporosis of hip is an acute onset and it is widespread and there is no narrow zone of transition in that. So the Carbol's combined necrotic angle gives you a very good picture when to go in and do what and whether can you be conservative or you have to operate. So regarding the management, the best thing is to avoid COVID by all possible and practical means. There is no other alternative option than that. And early intervention for COVID is most important. The more you neglect, the more you end up in using steroids, the more you end up in having microvascular abnormalities and then end up in having this problem. So high dose vitamin D, tackling a steroid with another steroid is the best answer for that. We have published a nice article on this, wherein high dose vitamin D initially would decrease all the inflammatory markers, including D-dimers in COVID patients. So initially it was noted that 2000 units of prednisone would cause avascular necrosis over a period of 6 months to 1 year. But now COVID has brought down the threshold of this steroid usage to 300 milligrams. So it has brought it down to 1/6 or 1/3 of it. Henceforth, if this prednisone equivalent, when it taken to dexamethasone or betamethasone, it is 1/10. That means 30 milligrams of a dexamethasone, if it is used for a COVID patient who is having these high risk factors, it can cause AVN. In such cases, we should be very clear and evaluate them very early, within 3 weeks to 3 months with a simple MRI. That would give us a better chance to intervene early and save their hips. And also, kindly don't forget to evaluate for dyslipidemia, hyperuricemia and protein C and protein S. More specifically, lipoprotein A and homocysteine, these are all the neglected factors which come into this picture. When it comes down to classification and how to deal about it, to detect it early and try to evaluate it as early as possible with MRI as early as 3 weeks. It can give you a better result and save your hips. Thank you very much. Thank you.
Thank you, Mahesh. Now I call upon the next speaker.
Good morning. Greetings from Nizam Institute of Medical Sciences, Hyderabad. And thanks to the organizers for giving me this opportunity. Coming to my topic, THR in dysplastic hip. So by definition, dysplastic hip is a spectrum of diseases with inadequate development of both acetabulum and femur, and with resulting in either subluxation or dislocation. In view of the improper anatomy and biomechanics, the osteoarthritis is imminent in this case. And THR in such dysplastic hips is difficult and challenging, and anatomical variations do occur either in the acetabulum side or on the femoral side. And unlike OA hip, this total hip is done in very younger patients, so the chance of the revision is early because of the poor bone stock. Only to those patients with severe hip pain, with pain conservative management, surgery should be offered. Even in a dislocated dysplastic hip, if there is no pain, even with an alarming radiograph, surgery should not be offered. And coming to the pathoanatomy, on the acetabular side, which is shallow and small, there will be superior lateral wall and then anterior deficiency, abnormal version, and whenever there is a dislocation, the native acetabulum is filled with adipose tissue and there is decreased bone stock. And on the femoral side, there is short neck, coxa valga, excessive femoral anteversion, narrow intramedullary canal, and then the rectus trochanter is more posterior and there is leg length discrepancy. And you can see here, and there is a deficient anterior wall and the rectus trochanter is very posterior. And there will be soft tissue anomalies such as shortened musculature, infratrochanteric region, adductors nodules become transverse, hypertrophy of the psoas tendon, hip capsule, ligamentum teres and labrum, sciatic nerve is shortened, and then this is the Crowley classification, most popular one, and it depends upon the classification depends upon the femoral head subluxation percentage, and then the haptophylakitis classification is more simple, such as dysplasia, low dislocation and high dislocation, whereas the type 4 of Crowley is equivalent to that of the high dislocation. And preoperatively, you have to see about the hip range of motion and then midwinch discrepancy and the amount of trochanteric migration. And then coming to the radiographs, these are done only to know the amount of native acetabulum. You can draw a Renard triangle to locate the native acetabulum. And then on the CT scan, you should know the acetabular anteversion, femoral anteversion, and then combined anteversion. And then where to put the cup? It is the common question. There are two centers now. One is the anatomic hip center and the other one is the high hip center. In the anatomic hip center, actually, if you put a cup in the native site, restores the hip center and restores the biomechanics. But there is insufficient bone coverage and revision will be difficult and it's a complicated surgery to bring it down. Whereas a high hip center, there will be abductor insufficiency and abnormal mechanics, but it is the good bone is available there and adequate bone stock will be there and it is a simple surgery. So let us see what is literature is telling. Literature initially has recommended to put the place the cup in the true acetabulum and they have not recommended in the high hip center. But over a period of time, what happened? The Russotti et al. They came with a different concept altogether. They suggested when circumstances dictate, proximal positioning of the acetabular component without lateral displacement can give an acceptable result in the cemented hip replacement procedures. And then even from Japan, they have suggested that moderate high hip replacement, cup replacement without bulk bone grafting, more medial than the normal hip is an alternative durable solution. And then Ranawat group also has suggested that a durable fixation achieved with medialized high hip center in cementless THS for Crowley type 2 and type 3. And then even in 2020, Ismail et al. Have highlighted the importance of femoral shortening osteotomy in type 4 and type 3 Crowleys. And these are the common implants such as Wagner and Esrom stents, and then highly porous coated and the small uncemented acetabular cups can be used to bail out. And coming to the Crowley type 1 and type 2 subluxation. And all standard hip surgeon approaches can be used in this case. And then on the acetabular side, it is very easy. Identification of the true acetabulum and reaming and putting an uncemented cup that are a cemented cup in type 2 and 1 and 2 that will do the job. Whereas on the femoral side, high neck shaft angle and some increased anteversion will be there and monoblock stem is enough. And then this is a case, basically you can see the floor osteophyte, the amount of floor osteophyte you can see, you have to remove all this to reach the floor so that you can medialize the cup. That's what you have to do. It is a deformed head and the shallow acetabulum, and how to assess the depth of the acetabular floor. And you have to drill initially and look at the depth of the acetabular floor, and you have to ream this much to reach the floor. to ream this much to reach the floor. You can see this is after reaming the acetabulum, a concentric reaming is done. In spite of that, you can see there is some lateral uncovering. And this the end of even though this is a little high hip center, this is the normal bone, and that is good bone having a good capacity and good coverage over the implant. And coming to the Provide 3 and 4 dislocations, the posterior approach is the most common approach you have to take, and then you have to do a soft tissue release, initially adductor tenotomy rather than ITB release to be done, so iliopsoas release, piriformis and external rotators to be released, and if necessary a femoral osteotomy to be done. And whenever on the acetabular side, you have to identify the true acetabulum. How to identify the true acetabulum? You can go along the ligamentum teres, or the inferior capsule is in line with the tal, and then transverse acetabular ligament, and then bony landmarks, anterior wall, posterior wall, and superior wall. And you should not shy away to take the help of a fluoroscopy. And after reaming and a smaller diameter cup should be available, and you should be kept inside. And the cup position should be in relation to the bone landmarks also to be taken care. And then you can take the help of an intraoperative fluoroscope. And on the femoral side, there will be increased anteversion and neck shaft angle. The modular stems used to adjust the anteversion. The monoblock stem should not be used in this case. And then coming to the femoral shortening osteotomy. While reducing the height to the normal true acetabulum, there may be overstretching of the neurovascular structures and damage to the neurovascular structures. In such case, it is better to do a shortening osteotomy. The advantages are to correct the malrotation, to facilitate the easy reduction, and to prevent the neurovascular stretching. It is a subtrochanteric osteotomy. When it has to be done, it can be done either in the at the time of exposure. If you do an osteotomy while exposure, you can see a good exposure of the acetabulum, or at the time of reduction also you can do this exposure, osteotomy. The types of osteotomies are many. We routinely do a transverse osteotomy, which is simple and effective. And then a subtrochanteric osteotomy is done initially. The proximal fragment sleeve is put, and beneath the sleeve you have to do the osteotomy. Then look at the overlap of the femur. Then you do the osteotomy at the overlap. And before doing the osteotomy, it is better always to put circularized wires, and then palpate the sciatic nerve to assess the tension, and prophylactic circularized wiring should be done. Coming to the cases, and this is the case of a female 66 years with a type 1 Provide, a short neck, and then a dysplastic hip and overriding acetabulum. And because the changes are very minimal, a normal monoblock stem and an ordinary uncemented cup are used, and at the end of 6 months it is incorporated well, and the patient is doing well. This is another case of 43-year female with a dysplastic Provide type 3. There is a low dislocation. You can see this is the real acetabulum that is there. And in this case, we have to do a subtrochanteric osteotomy, and because these are and a uncemented smaller cup was used in the native acetabulum, and you should be ready with the plate and screws, and then SS wires, because sometimes we may end up having some small fractures. This is at the end of a 3-year follow-up. The fracture osteotomy is united well, and the patient is doing well. Plus 2 more slides. And this is another case where a 41-year-old female, a high hip dislocation with a pseudoacetabulum formation. This is the acetabulum, a native acetabulum, and